upon our chairperson, Dr. Shrikant Khade, to kindly come and chair the session. I think Dr. Rajesh, Raju is still yet to come. Dr. Alfven Viera, along with Dr. Amit Dond as my convener, and chairperson Dr. Shrikant Khade and Rajesh Raju will start the second session. I call upon Dr. Mukesh Doshi. He will be presenting a 20-year follow-up of earthquake victims, a longitudinal study.
Is it audible? Good morning, everyone. So we all aware that we have a big earthquake on January 2001, and that left with us mountain of debris, dead body and cries. We plan a long-term rehabilitation program because most of the time what we have realized, the surgeon has come, they do the surgery, but there is nothing was written on the paper or follow-up or a rehabilitation management. And we have seen a children less than 1 year who has lost both the legs. To plan for their rehabilitations, we have to start the temporary rehabilitation center in rural area. Then we started a follow-up, and still today, we are treating all earthquake victims free of cost on that area, whether it is coming from Ahmedabad or any other places. So 10 years follow-ups, we had given him a lot of paraplegics, we had given him a wheelchairs, and 20 years follow-ups, recently we have completed with enjoyment and happiness. Now what is a good stories about everything? You see the first day of the patients with the paraplegics, and they teach us a lot of new things with the new ideas, especially for a UTI infections. People try with a lot of medicine, but local medicine, what they teach us, and how we get the UTI control very fast, that was amazing. We started rehabilitation program with orthotics, physical therapy and everything. The first slide you can see how we have made a total spinal contact brace along with the bracings, physical therapy. Then we put it into a vocational training program. She fall in love with a boy. They married and they get a baby boy. Now it is another story of another girl, Rajgor. In 2001, you can see a small baby. We made a prosthesis for him, and we just gave him a child walker. After giving the walker, she coming with us today also regularly. And you can see the second photograph, third photograph, and now she is pursuing with the PhD in chemical engineering. Now it is a very interesting story about this lady. She has lost his one hand, and the people says, if you cannot do the bilateral activity, husband says, I will leave you. And it was a great challenge for us to rehabilitate her. So we made artificial hands immediately, getting supply from Bombay, and we fit the artificial limbs. She can do all bilateral activity, like combing the hair, making chapatis, writing and everything. And entire family is survived, and they can connect it together, and they live with happy life today. This is another girl, Chetna, who has lost his both the legs, daughter, husband, and a home. And such kind of a patience when we rehabilitate to him with so many technology, but we are a failure. And she lives only a wheelchair life. Now, this is the, again, very success story of a woman power. She met with the trauma accident, a knee amputee. Today she can dance, she can do garba, everything. She is doing a tailoring job. She is moving from one place to another place. She has made a female empowerment of more than 5,000 female who has become a tailoring masters, and she has given employment to the lot of people in the rural area, though she is a Aboni earthquake victim. So, and she has received a lot of medals. This is my all VIP patients who also injured during the earthquake, but we treat them very well. So my home taking message is very simple. It is easy to do the surgery, but plan for the rehabilitations. And really the challenge is lying down in the rehabilitation of any human beings. Thank you very much.
We welcome Dr. Rajesh Raju as the chairperson for the session. Can I welcome Dr. Aditya? Is he here? नहीं, वो last का.
Good morning, everyone. My study is a prospective randomized controlled trial comparing the clinical, radiological and functional outcomes between the supra-patellar and infra-patellar nail insertion techniques in the Indian population. As we know that the tibial intramedullary nailing was traditionally done by the infra-patellar approach where the knee is in 90 degrees of flexion. In this position, the pull of the quadriceps tendon tends to pull the proximal fragment anteriorly, which results in a procurvatum deformity, especially in the fractures of the proximal 1/3 of the tibial shaft. Also in this position, the fluoroscopic assessment of the reduction of the fracture fragments is a challenge. Also, infra-patellar approach is known to be associated with risk of damage to the infra-patellar nerve that may result in post-operative anterior knee pain. To solve these problems, the supra-patellar approach was introduced, which is done with the knee near extension or about 10 to 15 degrees flexion. Here, the deforming forces of the extensor mechanism get neutralized, so the risk of procurvatum deformity is less, and also the fluoroscopic visualization of the fracture fragments is easier. However, the supra-patellar approach is associated with risk of damage to the patellofemoral articulation, which has to be studied to know the efficacy of this approach. This is the consort flow diagram showing the study methodology. All the patients with extra-articular tibial fractures who presented to our level 1 trauma center were screened based on the predefined inclusion and exclusion criteria, and after taking informed consent they were then allocated into either the supra-patellar or the infra-patellar nail insertion groups. A total of 60 patients were recruited with 30 patients in each of the two groups, who were then followed up for a period of 6 months, following which at the end of 6 months the MRI of the knee joint and diagnostic knee arthroscopy were also done. The objectives were to compare the clinical, functional and radiological outcomes between the two methods of tibia nailing, and also to compare the intraoperative radiation exposure, the total blood loss and the operative time. The clinical outcomes assessed were the post-operative knee pain, especially the anterior knee pain and the knee range of motion. The functional outcomes were assessed using 3 scores: the knee society severity score, the patellofemoral subscale of the knee injury and osteoarthritis outcome score, and the lysome knee scale. The radiological outcomes were to assess presence of any maladduction, especially if there was any varus or procurvatum deformity, radiologically assess the fracture union, and also to look for any evidence of patellofemoral joint damage. This is the distribution of the duration of surgery of all the patients. Here the operative time we found was significantly lower in the supra-patellar group as compared to the infra-patellar group. Also the blood loss, again the average blood loss we found was significantly lower in the supra-patellar nailing group with a p-value of 0.02. The radiation exposure was assessed both based on the number of fluoroscopy shots that were taken during the surgery as well as the average radiation exposure noted from the C-arm at the end of each case. Here we did not find any difference between the two groups with respect to the radiation exposure. Clinically, the anterior knee pain as reported by the patients according to the visual analog score at 2 weeks, 6 weeks, 3 months and 6 months of follow-up. There was no clinical significant difference between the two groups with respect to incidence of anterior knee pain as well as the knee range of motion, which was comparable in both the groups. This table shows the functional outcomes, which all three scores were calculated at 6 weeks, 3 months, and 6 months of follow-up post-operatively. You can see that the mean values of all the three scores at all the 3 time points of follow-up was higher in the suprapatellar nailing group. However, on statistical analysis, there was no difference between these two groups. There was no statistically significant difference between the two groups with regard to the rate of fracture union as well as presence of any malalignment in the sagittal and coronal planes. MRI knee was done for 57 out of the 60 patients, of which 13 patients from the suprapatellar group and 13 patients from the infrapatellar group showed some evidence of chondromalacia, which was graded according to the modified outer bridge classification. There was no clinical significant difference in the incidence of chondromalacia seen between these two approaches. Knee arthroscopy was also done. It was done for 16 of the patients. Due to limitations posed by the COVID pandemic, we could not do it for all the patients. Out of 16 of these patients, 11 had some evidence of chondromalacia, of which 9 were of the suprapatellar group and only 2 of them were from the infrapatellar group. The chondromalacia was primarily seen over the medial and lateral patellar articular facets and the trochlear groove. This difference we found was statistically significant. Comparing the arthroscopic and MRI grading, we found that there was moderate correlation between the two with correlation coefficient of 0.44. However, the MRI tended to miss grade 1 chondromalacia, which was better picked up by the arthroscopy. There was one case where there was false positive chondromalacia, which was seen on MRI. However, on diagnostic arthroscopy, the articular cartilage was found to be normal. To conclude, the suprapatellar nailing of tibial shaft fractures may help to reduce the intraoperative time and the blood loss as compared to infrapatellar nailing with similar clinical, functional and radiological outcomes. However, there remains a risk of damage to the patellofemoral articular cartilage as evidenced by the arthroscopic findings, and we need longer term follow-up with a larger sample size to better assess the risk of patellofemoral arthritis following suprapatellar nailing. Thank you.
Thank you, Dr. Aditya, for a very comparative study between the suprapatellar and the infrapatellar nailing. But I think the conclusion till now, I think infrapatellar is more better than the suprapatellar, right?
Sir, in our study, sir, suprapatellar nailing, we got very good results. Even the operative time was lesser. Initially, sir, there may be a learning curve with respect to suprapatellar nailing. However, sir, after a few cases, it was equally technically easy as well as with comparable results as compared to the infrapatellar group.
But it is very difficult to convince the patients post-operative arthroscopic diagnostics.
Yes, sir. Sir, initially we had explained the patients, and a lot of them, they wanted to have the diagnostic arthroscopy for their peace of mind.
Yeah, very good.
Did you use tourniquet?
No, sir. No, for nailing, no, we did not.
Okay. Did you do an arthroscopy pre-op or
No,
only
sir,
post-op?
we did not do
How do you
pre-op.
compare then?
Sir, basically we have included only young patients less than 45 years of age who had no history of any previous knee pain or arthritis. That is a limitation of the study, but because of the issues with respect to pre-operative arthroscopy, we have only done post-operative arthroscopy, taking the assumption that since the patients were young and they did not have any symptoms, so most likely they may not have any pre-existing articular cartilage injury.
Anyone from the chair? Any queries? No. Thank you, Aditya.
I call upon the chairpersons to present him his certificate. Now I call upon Dr. Dhruv Shah to present his functional outcome of simultaneous ACL reconstruction and HTO for patient with medial compartment osteoarthritis.
Good morning, one and all. I'd like to thank Wiroc Max for this opportunity. I'm here to present a study on functional outcome of one-stage ACL reconstruction and HTO in medial compartment osteoarthritis. So as you know, knee instability in ACL deficient knees could be due to traumatic injuries or chronic wear. This deficiency can progress to medial compartment osteoarthritis, 5 times the higher risk of osteoarthritis in ACL insufficient knees is documented. Adding fuel to this fire is a varus. Faster progression of the medial compartment OA. There's an adduction moment force leading to a varus thrust. This varus thrust exerts additional strain on the ACL graft, which predisposes us to early graft failure. Traumatic ACL injuries are common in 20 to 30-year-old age group who progress to radiologically significant osteoarthritis at the early age of 30 to 50 years. A valgus HTO is a widely used treatment for medial compartment OA in the young and early stages. It reduces the adduction moment arm and thus prevents force on the medial compartment of the knee. What we aim to address is a simultaneous ACL reconstruction with the HTO should decompress the medial compartment, correct the axis, decrease the strain on the reconstructed graft by decreasing the varus thrust forces, and however the simultaneous surgery can prolong rehabilitation and theoretically increase the tibial slope, straining the graft. So O'Neill and James in 1992 first described this procedure as a one-stage procedure. So materials and methods: patients with medial compartment OA or tibia vara with ACL insufficiency, a scoring of an IKDC score, Lysholm score, range of movement and latchment test we used. We had a sample size of 22 patients. The mean follow-up was of 2 years, mean age group of 40.2 years, longest follow-up was a 4-year, 7-month patient, and score was the IKDC, Lysholm, Latchman, and knee ROM. So the patients who were included were ACL insufficiency with varus, age between 25 and 60, Kelvin-Lawrence grade of 1 and 2, a revision ACL with the secondary medial compartment OA. Patients excluded were the ones with lateral compartment osteoarthritis, age above 60, multi-ligamentous injury, and patient non-consenting. So this is one case which we had. Patient had a left-sided traumatic ACL tear 4 months prior. He had an anteriorly unstable knee, a tibia vara angle of 6.4 degrees, and a high predisposition to progression of the varus due to right side already having a 11.3 degree varus. This was the case of an ACL with HTO done for this same patient. These are some more cases which we have done for the same ACL with the concurrent HTO in a single stage. The results were a significant improvement in the scoring. The IKDC score improved from 34.48 to 86.20. Lysholm score went down from 37 points to 89 points. The mechanical femoral tibial angle was corrected from an average of 8.2 degrees of varus to 0.8 degrees of valgus. Significant improvement in the laxity evaluated by the same clinician evaluating the Latchman test pre-surgery. These are the scores which we had: mechanical axis change, which was significant, IKDC score and Lysholm score. So combined ACL and HTO has the obvious advantage of undergoing a single procedure with a faster recovery. The need for it is decreasing the stress on the ACL graft due to decreasing the varus adduction forces, delaying the progression of medial compartment OA and delaying the need for conversion to arthroplasty, and providing a stable knee joint with the corrected access to younger individuals who wish to continue sports activities. The changes in the operative steps for a single stage would be use of a table which can be broken and straightened intra-op for the ACL and then for the following HTO part. Preparing the graft and the femoral tunnel before the HTO to prevent any hyperflexion of the osteotomized knee. The plate should be placed on the posterior medial aspect to decrease the tibial slope and provide space on the anterior medial tibia for drilling of the tibial tunnel. The plate should be fixed with posterior screws first, followed by tibial tunnel drilling and the anterior screws inserted. After drilling of the tibial tunnel, there's an insertion of a metal dilator during drilling of the anterior plate screws to prevent interference of the tunnel and the screws. 3 out of 22 patients had a positive Latchman test after surgery but had an improved functional outcome. 2 out of 22 patients had radiologically significant progression of the medial compartment osteoarthritis. There was no significant change in the tibial slope pre and post operatively, and no patients in the study period we had who reported any graft failure. So at our center we were able to reproduce satisfactory results in patients and thus can conclude that one-stage ACL reconstruction and HTO is a suitable option with ACL insufficiency and medial compartment osteoarthritis. However, very little has been described in the literature, and larger studies should be able to validate as well as find any other shortcomings of the above described procedure. These were the references. Thank you for your attention.
Yeah, one question, Mr. Dhruv. Where the medial meniscus status was considered?
Yes, sir. So when we underwent the diagnostic scopy and during the MRI, we had two patients who had a medial meniscus tear, and both of them were repaired intra-op. But because of we were not able to correlate that with the progression of medial compartment osteoarthritis. Hence, we've excluded that part of the study. But a larger study would be able to help us with that.
Yeah. If at all the medial meniscus is considered for repair, were there any like you can say protocol in physiotherapy change?
No, the physiotherapy change for anyway was which we halted for 3 weeks because of the healing of the HTO, and then we progressed with general post 3 week rehabilitation for the ACL with the meniscus.
That's it. Anyone from the audience? No doubts? Great.
Thank you, Dr. Dhruv. Can you please collect the certificate? Thank you. I welcome the next presenter, Dr. Aditya Kashikar.
Good morning, everyone. So this kind of MRI picture you come across in your clinical practice, where patient has come with severe stenosis at cervical, dorsal, and lumbar level. So as a clinician, you are confused. Triple tandem, oh my God, how should I address it? Which investigation, neurologist involvement? So many questions come to your mind. Whether should I do multi-stage or single-stage study? So all this confusion comes to your mind. So in next 5 minutes, I'll be brushing upon how to manage these kind of patients where we come across triple tandem stenosis patients. So as a clinician, what is the causative region, which investigations to be done, as there are no clear-cut guidelines in literature. So we are confused how to go about it. So we did a retrospective review of prospectively collected data of consecutive patients who were diagnosed to have triple tandem stenosis. Same team of surgeons did this surgery at single stage procedure, and between from August 2009 to Feb 2020, there were 12 male patients and 5 female patients. Patient's functional outcome was assessed at 6 monthly interval with VAS and MODI. Clinical presentation wise, these were the commonest symptoms with which patients presented to us. So inclusion criteria was patients listed in earlier slide were all included, with exclusion criteria of unfit patients declared by medical team or any neurological cause contributing to the etiology. All patients were investigated by X-rays, CT scan, MRI, and neurophysiological studies. Neuric grading wise, pre-operative, this was the grading, where grade 4 was the max patients with which we came across. All 17 patients underwent same stage triple region decompression surgery by same team of surgeons. The training surgical steps and pre and post surgical protocols were same at all hospitals where we did this surgery. In last 5 years, we started using ultrasonic bone scalpel. This is one of the cases where we did long segment laminectomy, where you can see intact lamina taken en masse. So one may question that why we did only laminectomy, why fixation was not contemplated in such a large laminectomy cases. So we believe that these cases are all autofused, stable cases. Most of them are having OLF or DISH. And how one will decide how many levels to fuse, because those were extensive involvement of the compression. And basically we are treating these patients for their neurological symptoms and not for actual pain. Post-operatively, all patients were subjected to vigorous physiotherapy rehabilitation, both during their hospital stay and post-discharge. Imaging was done at 4 months, 12 months. So, VAS-wise, this was the improvement in VAS scoring pre and post, both arm, neck, and back and leg wise. MODI improved from pre-operative average mean of 74.42 to 20.25. We came across dural tear in 7 patients, out of which 6 were in dorsal region, 1 was in lumbar. Neurodeficit was found in 5 patients post-surgery. And neuric grading-wise deterioration in neurology was depicted in this chart. Out of these 5 patients where neurodeficit was seen, 2 patients recovered and 3 did not improve neurologically. And out of that 1 patient, we had to do revision decompression 2 years later. So this is one of the cases where there is triple tandem stenosis, and this was a post-operative MRI showing very good decompression. Second case with multi-level cervical, dorsal and lumbar level stenosis with post-operative very good decompression follow-up MRI. So in literature, there are no large series showing any single stage triple regional stenosis decompression surgeries. So most of them are case reports where multi-stage surgeries was done. Our is the largest series up till now. Unlike Western population, max population is devoid of enough government-aided or private medical insurance support in our region of world. So financial burden-wise also it's quite huge if we consider 3-stage versus 2-stage. And as a mentality, Indians avoid multiple surgeries. And financial aspect also, we feel that single-stage surgeries, one can reduce the cost by almost 33 to 50%, and loss of working days also we can save on. So take-home message is, single-stage decompression surgery for proven cases of triple regional stenosis is an effective surgical way of treatment with reasonable good outcome. There has to be high level of suspicion. One should rule out all non-spine causes before taking them up for surgery. Don't hesitate to asking list of investigations. Newer modalities like ultrasonic bone scalpel can be used safely, and good vigorous physiotherapy is must post-surgery. Thank you.
Any questions?
Sir, frankly speaking, neurophysiological studies are just to document on paper. They don't decide your level of surgeries. This is just to decide whether there is involvement so basically, that is not going to decide your level of surgery, sir. It's just to document whether there is any neuropathy component or any muscle involvement or basically posterior column dysfunction in ACCPs. So just to prognosticate point of view, because post-surgery, if patient is developing any neurodeficit, priorly already patients have been counseled about the neurodeficit part. So at least you have evidence that neurophysiologically also they were compromised pre-surgery. So that helps us in post-surgical counseling also. Not necessary, because we have seen that to start with only their MEPs are low. Even if you do neuromonitoring with such kind of severe stenosis to start with. So baseline is only to start with it's low. So it's not like where normal patient is there where MEPs are normal and later on during surgery there is a decrease in MEPs. So there is no baseline with which you can compare.
But recently we did one surgery where intraoperatively when we turned the patient before operating the MEP had fallen to
Correct.
zero. Then we reversed the patient and then we took the patient's consent and then went to
Extremity.
Good morning, chairpersons on the dais, members of the faculty, and my colleagues. Soft tissue sarcomas are rare neoplasms, and they are often treated with a multidisciplinary approach using radiation and wide local excision. While there are many advantages to limb salvage surgery, post-operative morbidity in these patients with soft tissue sarcoma may result in a functional decline, decrease in quality of life, and increase in the number of operations with wound complications which may occur in as high as 45% of the patients. A multimodality therapy for this disease yields excellent control in the local tumor, and the survival has significantly improved. However, the risk factors, even though they have been identified, because of the variation in the reported factors, there is no particular contributing factor for wound complications. So they may be patient-related, tumor-related, or treatment-related factors that can contribute to the final wound outcomes in these patients. So there has been a strong attempt in the sarcoma community to create a nomogram which will recognize these patients better who are expected to have a wound complication post-operatively. So a single high-volume center under the University of Toronto and Mount Sinai Hospital identified more than 3,000 patients with soft tissue sarcomas, and we validated the existing nomogram. So with the external validation of the nomogram, the rate at which we were able to predict these wound complications in patients was an acceptable 70%, which is not excellent, but just acceptable. So we therefore asked the questions, what are the additional risk factors associated with wound complications in these patients? And can we improve the predictive nomogram to assess the risk of wound complications in individual patients after resection of soft tissue sarcomas? Maybe it's not a triangle, but a square of factors that are affecting the wound outcomes in these patients. So do the surgical factors affect outcomes as well? In the 3,000 patients that underwent soft tissue sarcoma surgery, we identified and subclassified the surgical factors that were analyzed. So details on the anatomical site, extent of resection, method of reconstruction, as well as the type of closure at index surgery were analyzed. And as expected, even though the nomogram only used an upper limb versus lower limb classification, on our subclassification, we found that the groin and the axilla was significantly more prone to wound complications postoperatively. When coming to resections, tumors that needed to be resected along with vessels were significantly at a higher risk of wound complications in the final postoperative course. Addition of reconstruction, everybody requires reconstruction to resume function and mobility. So addition of reconstruction, whether it's a vascular procedure or adding a metallic prosthesis, significantly improved the complication rates. And lastly, the technique for closing the wound played a significant role in the final outcomes. So a multivariate analysis of the surgical factors significantly played a role in determining the outcomes of these patients. And the next step would be to improve the predictive nomogram and create a new updated nomogram to include the surgical factors as well. Thank you.
Any questions?
When you excise a sarcoma, there will be a large soft tissue defect that will be remaining. So, that can be a source of hematoma collection. Would that, obviously change your surgical technique, because this will straight away lead to a wound complication?
So if there is a large defect without any muscle in the base of the defect, we need to bring in healthy muscle, which will act as a absorption base. If there is not, then we do a rotation flap, free flap. Also, all patients which undergo extensive vascular dissection, the lymphatics have been removed with the tumor, so they need a drain for a long period of time. And the drain has to be kept till it is significantly low, even if it is beyond 2 weeks, continuously significantly low till it is removed. So the body has started developing the absorption channels, and only after which the drain can be removed.
So these large defects, can it be better treated with this way and a rotation flap primarily, or putting a vacuum dressing, which is the,
So vacuum dressing will need to be skin grafted after a healthy granulation is achieved, but the defect may be so large that even a skin graft may not completely heal. So closure with healthy skin and muscle is always advisable, because most of these patients either pre-operatively or post-operatively will require radiation therapy. So skin graft is not the best solution.
Thank you.
Thank you, Dr. Manit, for a very good presentation. I thank all the presenters on behalf of Wiroc team for their presentations, and wishing all the best for future presentations also. Thank you.